Thank you. So, honorable audience, I'm pleased to share with you today this clinical case titled UV dermoscopy insights revolutionizing infant erythroderma diagnosis. We observed the case of 3-month-old infant exhibiting a widespread rash that had been provoking discomfort for 2 months. The mother mentioned the family background of nighttime itching persisting for the past 2 years, and it should be noted that the child was initially put on several treatments with no improvement. Then he was referred due to concerns of Lehner's disease. Upon dermatological evaluation, the infant displayed dry, scaly erythroderma with a wet sand appearance, with also a diaper dermatitis with yellowish grass on scalp. So, what are the possible diagnoses to consider? Is it Lehner-Musus erythroderma, an erythrodermic atopic dermatitis, or other? The involvement to the palmar-plantar region, as well as the diffuse nail involvement with pachyonychia, subungual hyperkeratosis, onycholysis, and paronychia were the reasons why we decided to use our dermoscope. Dermoscopic examinations revealed various signs, including the delta glider sign, the gray edge line, and the jet with contrail sign. The same signs were observed in palmar-plantar examination with the distinctive noodle pattern. And lastly, let's note this very impressive nail damage with this huge number of burrows. UV dermoscopy highlights the blue-bright fluorescence of the burrow as well as the bright green fluorescence emitted by the female mite's body with the ball-like appearance and jet with contrail signs that are so obvious with UV mode. A presumptive diagnosis of crusted scabies was made, and the direct exam revealed several sarcopscaby mites. Our approach was to put the child on 10% urea-based keratolytic agent on the palmar-plantar area and benzyl benzoate 10% lotion daily. We also insisted on the treatment of the environment and close contacts, and the treatment undertaken led to a significant clinical improvement with the disappearance of dermoscopic signs of scabies at the 15-day follow-up assessment. And the decision was to maintain a treatment for a further 15 days, focusing on parangal area. And here, at the 30th-day checkup, the skin lesion had completely disappeared, but subungual hyperkeratosis persisted, and then disappeared at the 4th month follow-up. Moving on to the discussion section, crusted scabies is rarely reported in infancy, especially in healthy children. Pruritus is particularly pronounced in this age group, and the most commonly affected area are the palms. To evaluate the risk factors, a French study was conducted on 20 children with crusted scabies. Known risk factors include immunosuppression, physical debilitation, and intellectual disability, and other factors have lastly been described, including delayed diagnosis and the use of steroids, as in the case of our patients. It is noteworthy that there are no reported cases of crusted scabies in newborns, as well as no previous dermoscopy description in infants. Dermoscopy could significantly increase the accuracy of diagnosing scabies, especially in cases with a puzzling clinical appearance and early onset, as in our patient's case. So here in the first image, we see with the blue arrowhead the gray edgeline sign. Yellow arrows show the delta glider sign trailed by the jet contrail. The second image shows the noodle-like pattern consisting of accumulation of several curvilinear burrows, and the last image shows the recently described wake sign, where we see the burrow with the black lines and the wake-shaped skull with the dashed line, together presenting a Y-shaped lesion. It is important to keep in mind that the noodle-like pattern is characteristic dermoscopy sign of crusted scabies. UV dermoscopy was shown to further increase the diagnosis accuracy by accentuating the burrows seen as serpiginous bright blue lines corresponding to dry keratin scales, and also evoking the bright green fluorescence of the mite. And here, with the exception of the area representing the delta sign in polarized dermoscopy, we can see the whole parasite in the UV dermoscopy, which looks like a ball. So when the mite is not clearly visible in a polarized mode, we can switch to UV mode to clarify the diagnosis. This gives us a more effective imaging method for diagnosis and treatment control of all forms of scabies. The recommended management is a combination of topical and oral agents, and the recent systematic review encourages evidence that ivermectin is safe and well tolerated in small children weighing less than 15 kilograms. A word about nail involvement in scabies. There are only a few cases in previous literature, and it is frequently mistaken with other conditions as nail psoriasis and onychomycosis. And combination of ivermectin with topical scabicides and oral topical keratolytics seems to be the most effective treatment for scabies of the nail. So our case illustrates the confusing etiological diagnosis of erythroderma in infants. In this case, nail and palmar-plantar involvement were the mainstays of the diagnosis. And to conclude, I'd like to point out that the rise of UV dermoscopy opens a new box of previously unobserved clues, including the observed green fluorescence of the whole parasite body. This might be especially helpful for novices in clinically non-obvious cases, in future AI-assisted models, or serve for test of cure. And thank you for your attention.